Take note in this case, the patient's unaffected arm supports the affected arm, reducing pain. Here, the physiological position of the bones of the shoulder joint are demonstrated using an anatomical inlay. Highlighted now are the head of the humerus, the acromion, the coracoid process, and the glenoid cavity of the scapula. An animation is used to show the anteriorly dislocated head of the humerus from different angles. Take note that the head of the humerus is trapped behind the glenoid cavity of the scapula. This is typically seen in an anterior dislocation. The prominent humeral head can be palpated anteriorly on physical examination. Also, the loss of deltoid contour can be seen under the acromion. Based on these clinical findings, an anterior shoulder dislocation can be diagnosed. It is advised to examine the neurovascular status of the upper limb before starting the reduction. Although most injuries are caused at the time of dislocation, some may occur during the reduction. Adequate analgesia should be administered and, if required, sedation. This should be done as per local pain management protocol before positioning the patient. The patient is placed in a supine position. This is done slowly and with care. The shoulder should be supported to reduce the pain as much as possible. The primary physician is positioned next to the patient. A bit of traction is exerted onto the affected shoulder in a caudal direction by the physician, as this may reduce the pain. Relaxation of the shoulder muscles is essential for a successful reduction. Analgesia and patient comfort are therefore essential. The elbow is extended and traction is continued. A sheet is carefully placed in the patient's axilla on the affected side by a second physician. This sheet can be used to exert countertraction during the reduction. When the sheet is adequately positioned, the primary physician increases the traction while countertraction is provided by the second physician. Care should be taken to exert continuous traction. If this is not done, the patient's muscles go into spasm. This is maintained for a couple of minutes. If reduction is not attained like this, the primary physician can exert even more traction using his foot. This might be needed when the head of the humerus is fixed behind the glenoid cavity of the scapula. One shoe is taken off, a protective cover is put on, and the foot is placed in the axilla. The physician can feel how much caudal traction is exerted and how much countertraction should be exerted using his foot. Using this technique, the head of the humerus can be levered. While exerting traction, the arm is exo-rotated. This way, the head of the humerus is rotated anteriorly, which will help to unhook the head of the humerus, which will aid reduction. Here it is shown again. And again, using an animation. Note that the head of the humerus is moved caudally. The arm is externally rotated, and the shoulder is reduced. A typical palpable and audible clunk can be felt and heard on reduction. With successful repositioning, the patient's pain is immediately reduced. The foot is removed from the axilla and little traction is still exerted, as this reduces the pain. The sheet is carefully removed, and the arm is positioned across the patient's body and should be supported while doing so. External rotation of the shoulder joint should be avoided, especially with the arm in 90 degrees of abduction. The patient is helped while the affected shoulder is supported by the physician. Physical examination is used to evaluate the procedure. In a successful reduction, the prominent head of the humerus is no longer palpable and the deltoid contour is restored. The stability and function is tested by the physician slightly flexing, extending, and abducting the patient's shoulder joint. A sling is used after the reduction to maintain the position of the arm. Take note that post-reduction care is as per local protocol. The angle of the elbow should be less than 90 degrees so the hand is positioned higher than the elbow to prevent swelling of the forearm and hand. It is advised to repeat the neurovascular examination in order to make a comparison to the findings prior to the reduction. If a change is noted, it can be acted on. It is advised to perform imaging studies after the reduction. This is in order to evaluate the position of the humeral head and to detect any fractures.